Hi, everyone. My name is Sarah Sieper, and I'm the Knowledge Management and Strategic Communication Senior Associate on Momentum Integrated Health Resilience Project, funded by USAID. I will be your host for this short video series, which features interviews from staff on our project as I highlight insights from their work as it relates to the overarching goals of our project. Momentum Integrated Health Resilience works alongside local organizations, governments, and humanitarian and development partners to strengthen health resilience, provide high quality, respectful maternal, newborn, and child health, voluntary family planning, and reproductive health in fragile settings to improve health outcomes. First episode of this series will focus on social accountability in fragile settings to support these health outcomes. Social accountability is defined as a process that enables the inclusive participation and collective action of citizens in civil society organizations in public policymaking and implementation so that state actors and service providers are responsive to citizens' needs and are held accountable. Today, we have Camden Hoffman, PhD, MPH, MA, who is the social and behavior change lead for Momentum, to discuss some of the ways the project is utilizing social accountability to improve health outcomes. Welcome, Camden. Go ahead and introduce yourself and talk a little bit more about your role on implementing social accountability on the project.
Sure. Thank you so much, Sarah. It's a pleasure to be here. So I've been a SBC lead on the project Momentum Integrated Health Resilience, or MER, almost since the beginning, about 3.5 years. We've come a long way in social accountability. I myself, I'm a technical director for SBC at Chorus, as well as the SBC lead for MER. Social accountability started as a strategy under MER, and having over a decade of experience in social accountability and seeing the settings in which we work, I realized that social accountability really should be a guiding principle for our project. And so I advocated with our team and with our donor to have it as a guiding principle. And now we're implementing social accountability in all of our MER countries to date.
Thank you so much, Camden, and welcome. First, I just want to have you talk a little bit more about what social accountability is.
So I think you summarized it quite well at the beginning. I think some things that I would add to that, especially in fragile settings, is that it really gives a voice to the most vulnerable and marginalized. One key aspect that is sentinel to the process is to have a two-way dialogue. And that's that's between a group that's providing services to citizens or clients, and then those that are receiving services. And those services could be health services, education, financial. We happen to focus on health because we're a health project. So we involve providers and clients in the community. Also looking again at the most marginalized and vulnerable. And it's a joint decision-making process to prioritize issues that are the most important to both the providers and the citizens moving forward and taking actions together to solve those issues.
Thank you for that. So, can you talk a little bit about how social accountability is linked or associated with the technical area of social and behavior change?
Well, to date, they've been a bit siloed. Social and behavior change, the lexicon in that area vis-a-vis social accountability is a little bit different. I was actually just on a call earlier today, and we were talking about how some governments they shy away from social accountability but welcome social and behavior change because it seems less daunting or imposing that there is that accountable side. So while there's limited literature that shows the linkages between SBC and social accountability. But if you look at MER's theory of change within our strategy for social accountability, the outcomes from implementing social accountability are naturally related to social and behavior change. And some of those examples are improved client-provider interaction, increased trust, provider behavior change, and then, of course, increase healthcare seeking by clients.
Thank you for that. So you mentioned an example of how project outcomes may be influenced by social accountability approaches. Can you talk more about some of the specific approaches that MER is using and adapts in our programs?
Sure. So, based on the criteria in our strategy, our social accountability strategy, we've narrowed it down to two that we're using in our countries, about half half. We're using Partnership Defined Quality, or PDQ, that was developed by Save the Children, and we're also using the Community Scorecard, which was developed by CARE International. Those approaches differ slightly in the way that they're implemented. Of course, PDQ focuses more on quality from the beginning, whereas the community scorecard allows for a little more exploration of community issues. However, in our case, we end up focusing on health issues and quality as to date what we've seen from implementing that. I think some adaptations that we've had to make within our MER countries have been related to the fragility of our countries, and specifically, limited social cohesion. And it's not if, it's when we'll have a shock or an ongoing stress. And some of those have been, a key part to that two-way dialogue is an interception meeting, where after you've explored both from the provider and the community side their issues, you bring everyone together to discuss those issues and prioritize to make an action plan. And in our experience in South Sudan, for example, we had some very sensitive issues. And so what we decided to do was make that from the interception meetings usually one day. So we expanded it to 3 days. And on the first day, we talked about sort of non-behavioral issues, right? So like one issue that came up is, this bridge always goes out because of the flood that comes every year. And then the second day, we talked about more workplace issues, what's available at the clinic, et cetera, really building a rapport. And then by the third day, we started talking about those behavioral issues and the client provider interactions. And it allowed for that rapport building so that by day 3, people felt more comfortable with the issues. Even having said that, we also put in place a mitigation strategy, sort of like what we use in the United States as a parking lot. I discussed with my colleague what's culturally relevant to sort of this parking lot if there are issues that become heated. And my colleague said, usually we do a traditional song or traditional dance to kind of get the mood back on track. And I said, well, can you add that to the interface meeting at the beginning and let everyone know that if things do get heated, we will have a traditional song or a dance, because we don't want to get stuck on things that, this isn't blaming. There's no blaming or shaming. It's exploration and prioritizing what is meaningful to both the providers and the clients and citizens. And so we put that in place, and luckily we haven't had to use it yet. But in the principle of do no harm, we do look ahead for possible issues where we would need to have a mitigation strategy in place.
Thank you for highlighting, those two approaches and sort of the conversations that you've had directly in the field. So something that we spoke about earlier was the connection between social accountability and social behavior change. And you mentioned the project's theory of change and showing how there can be linkages between social accountability activities and SBC outcomes. And as a result, we do expect to see, access and utilization of FP and RMNCH services, improved quality of care and service delivery. I know you're part of the high impact practice on how social accountability can improve family planning information and services. Can you talk a little bit more about the outcomes of the high impact practice and sort of this relationship between social accountability and these improved health outcomes?
Sure. So what's interesting about that high impact practice is that it falls into the enabling environment category within the HIPs, as we call them. And there are results that are showing improved, statistically significant in places where they've been able to do randomized control trials in Malawi and other places, quasi-experimental designs. But we're definitely seeing some of those outcomes, specifically improved client, I think I said improved client provider interaction, behavior change. But I think one of the most important parts of that HIP were the 4 questions that came out and where we don't know enough information. One of them is how to scale
Mhm.
and how to work at all 4 levels. One is how do we work in places that have less social cohesion, such as fragile settings. Another question is how do we measure trust? So those are a couple of them. I'm forgetting the 4th one right now, but we can provide a link later to the HIP. But it just goes to show that we focused on family planning and we're seeing some of those outcomes, but those are also in very controlled settings. In our fragile settings, we can't control certain factors. So it's a little bit more difficult sometimes to be able to measure those outcomes. I hope that answers your question.
Yeah. So, you did know that there's sort of more to be done to really understand the impact of social accountability in fragile settings. Why do you think the use of social accountability approaches may be, particularly important for fragile settings? And, how are the approaches like PDQ and CSC that you mentioned earlier sort of done differently in these settings, if at all? I know you mentioned some adaptations, but, anything you'd like to add on that?
Sure. I think, as I said earlier, one of the most important things is giving citizens a voice. And I specifically remember our first time we rolled out PDQ in Mogwi, we had a sensitization meeting, we meaning my team there, who are the ones on the ground doing all the work. We just support them from here. And I'm really proud of the work that they do. My colleague told me that they were wrapping up the meeting and the community they didn't want to stop the meeting. And they were afraid that if they went away, nobody would listen to them again. And so my colleague had to ensure them that this is a sensitization meeting just to let you know of what process we want to use to engage you moving forward so that you do have a voice. And I think that that's particularly important in fragile settings is that you do have these marginalized groups and, what we're looking at, IDP, internally displaced persons and refugee camps and, pastoralist settings and, places where tribal conflicts where it's difficult to raise your voice and have it heard. And so I think that's one key aspect that's really important in the settings that we work in fragility. I would say the second is recognizing that in fragile settings, we've experienced provider burnout.
Mhm.
Or limited numbers of providers, and how do you deal with that when it's difficult to change, and trying to find solutions on coping strategies for providers or task shifting, and
Mhm.
really thinking about what that means at the clinic level and for the clients, right? So if providers and clients are able to sit down and if that's an issue, right, like long waiting times, maybe they
Mhm.
come up with a solution that they have, they alternate days and different people come on different days, or, they offer us a certain, and in some cases we have this where we have dedicated family planning days.
Mhm.
So we know that family planning clients will come on that day and they know that they will be served in family planning should they choose to seek
Mhm.
that service, if that answers your question.
Yeah, that definitely covers it. So, Momentum Integrated Health Resilience, as a project has multiple expected outcomes, including to strengthen health resilience and improve overall health in the countries that we work. Can you talk a little bit about the relationship between social accountability and health resilience? can, social accountability help to enhance resilience? And if so, what are the pathways for that?
Sure. So within our social and behavior change strategy to enhance resilience, we have five principles. And the first principle meaning it should be done, and we need to build the evidence base behind it. And the first principle within that strategy is to have a two-way dialogue, i.e., social accountability. And so in the essence of looking at SBC to enhance resilience, we're looking at social accountability. Now that we've furthered along our definition of resilience, we have sub-factors within our three resilience capacities, namely absorptive, adaptive, and transformative. And what we're really hoping to do with the resilience team is right now we're taking a mapping exercise of where we're doing all social accountability and SBC activities in every country. And we've brought in the resilience team so that we can look and see what sub-factors may apply to the social accountability approaches that we are implementing, such as individual or group agency, locus of control, self-efficacy, and how can we measure those types of sub-factors in different types of qualitative and quantitative metrics. So whether that be through an exit interview, questions in a household survey, complexity aware methods such as most significant change, which is what we're going to be using and has been used frequently to measure change within the community scorecard, both in Latin America and Africa. So I think that's really where we want to head in PY4 moving on, trying to really link it to those resilience capacity and their sub-factors, which are really grounded in determinants of collective and individual behavior.
Thank you so much for that. That was very insightful in sort of connecting the two areas. So I want to end our interview with this question. For global health professionals out there sort of working or those working in adjacent fields who are interested in incorporating social accountability into their work, where should they start? Websites to visit, resources to review, trainings to participate in, things of that nature.
Sure. So I was very, very happy as co-chair of the Systems for Health Working Group in 2022, where we were able to develop a repository under the core group of materials and social accountability, and it is quite extensive. We have peer-reviewed literature, we have gray literature, we have websites to visit, we have implementation tools, monitoring and evaluation tools, and they're all organized, by tabs, and you can search that. And I'm sure we can provide a link to that to anyone who is interested. And then, of course, myself and my colleague Beth Outerson, who is implementing social accountability in our MER countries, we're more than happy to talk about this with anyone that would like additional resources. And there are some other momentum projects, such as MCGL, who has developed an interactive report on their work in youth-led social accountability. So we're also looking at what not only what's happening within the Momentum Suite, but beyond as well, to sort of capture beyond within that repository, and then keeping that repository live and building on additional materials as they become available.
Thank you so much, Camden, for your insight and for sharing your knowledge on how social accountability approaches can impact health and health outcomes in a positive way.
Well, thank you for having me, Sarah. It's been a pleasure, and I really hope that those that watch this webinar series do reach out, because social accountability is near and dear to my heart, and I would love to see it expand.